Our next topic to look at are lung volumes and lung capacities. As the name suggests, this is the amount of air at different points in time during breathing, normal quiet breathing, or forced breathing. These volumes are typically measured using an instrument called a spirometer, and the information you get from the spirometer is often in the form of a spirogram, which is this graph shown at the bottom. We're going to be really using this graph to better understand these volumes and capacities. And to best understand this graph, you need to understand that we work from the right towards the left. In essence, this is like the information coming across the screen or out of the machine on a piece of paper. So the start of the record is here, and we work our way this way. Lung volumes and capacities are extremely important because in the clinic, we use this information to assess someone's respiratory system. So try not to just memorize these as definitions, but really understand these volumes. And one way to do that is to actually breathe while you're thinking about these lung volumes. So for instance, I'd like you to breathe normally right now. Quiet inhalation, quiet exhalation. As you breathe in and out, that volume that's coming into the respiratory tract and back out of the respiratory tract is known as tidal volume, or TV. So by definition, this is the amount of air inhaled or exhaled with each breath under resting conditions, aka normal quiet breathing. Varies a bit from person to person. There's a lot of things that affect lung volumes, such as size. So larger people have larger chests, smaller individuals have smaller chests. We're going to use some normal numbers here, some averages of adult volumes. Notice male and female, it's about 500 milliliters in, 500 milliliters out during normal quiet breathing. If we look at the graph, we can actually look here and work our way this way. So you breathe in 500, breathe out 500. Breathe in 500, breathe out 500. During normal quiet breathing, that volume is known as tidal volume. Let's then imagine we take a deep breath. So after you breathe in the 500, how much more can you breathe in? That is known as inspiratory reserve volume. So how much do you have on reserve that you can breathe in after the 500? So by definition, this is the amount of air that can be forcefully inhaled after a normal tidal volume inhalation. On this graph, let's start back here at the start of the record. Normal inhalation, normal exhalation. Normal inhalation, then we inhale that inspiratory reserve. So that volume is roughly 3,100 milliliters in a male, 1,900 milliliters in a female. Then you have to exhale that volume. So this is the same volume, you're just now exhaling it. Then you exhale the tidal volume. How much more can you forcefully exhale? That's called expiratory reserve volume. So by definition, this is the volume of air that can be forcefully exhaled after you exhale the tidal volume. Finally, there's a volume left in the lungs. You cannot completely empty lungs. If you think about it, if you did, they would be collapsed. They'd be empty. So the volume remaining in the lungs after forced exhalation is called residual volume. Notice that this line cannot go down to zero. So this volume here is known as residual volume. So these are the four primary lung volumes. And the best way to do it is to mimic what this spirogram suggests. So you normally quietly breathe, inhale, exhale, then you take a deep breath in, you breathe that volume out, and then you keep exhaling. So my analogy of this expiratory reserve volume is if you were trying to blow out birthday candles and you're trying to get even more and more air out. You're squeezing your chest in, you're using your internal intercostals to compress your chest and forcing as much air out of the lungs as possible. That's called expiratory reserve. On the next slide, we're going to cover the lung capacities. Now, lung capacities are combinations of specific lung volumes. So you add together certain lung volumes to give you a capacity. So for instance, inspiratory capacity is the maximum amount of air that can be inspired after normal expiration. So in essence, you are adding your tidal volume and your inspiratory reserve volume to get your inspiratory capacity. Functional residual capacity, or FRC, is the volume of air remaining in the lungs after a normal tidal volume expiration. This is an important one. FRC, which shown on the graph is right here, is how much volume is in the lungs after you quietly exhale. This is an important volume because it's what you have left in that lung. If you were not to take another breath, how much air is in the respiratory tract that you can get oxygen from. That's a functional residual capacity. It's very important for anesthesiologists to understand FRC because anesthesiologists stop the respiratory system. And there's a time period from when you stop your patient from breathing to where you intubate. During that moment in time, that person is surviving on their functional residual capacity. Once that oxygen has been completely diffused into the bloodstream, there's none left. So the person needs oxygen after that. Next one, vital capacity, or VC. Maximum amount of air that can be expired after a maximum inspiratory effort. Basically, if you were to think about just forcefully breathing, what's that capacity? So that is that's this bar here, vital capacity. So it's the maximum amount of air that is being exchanged during forced breathing. So if you were to think about forcefully breathing, breathe as much air in as possible, exhale as much as possible. That volume is called vital capacity. Total lung capacity, you just add in that residual volume. So total lung capacity is vital capacity plus residual. So the total amount of volume inside the lungs. So the lung volumes are most important. We need to understand the 4 lung volumes. The next most important would be these 3 here. FRC, VC, and TLC. Next topic I want to talk about are external respiration, which is gas exchange within the lungs, and internal respiration, which is gas exchange at tissue. This is all simple diffusion. So if we understand simple diffusion in that molecules as well as gases move from high amounts to low amounts, this should all make a lot of sense. What we're looking at here is a drawing that represents the entire cardiovascular circuit, systemic and pulmonary. So here is the systemic circuit at the bottom, heart to cells, back to the heart. Here's the pulmonary circuit, heart to lungs, back to the heart. So it's a complete circuit. We're looking at the exchange that's occurring between the alveolar air in the lungs, and blood in the pulmonary capillaries. Then we're going to look at exchange that occurs from systemic capillaries to tissue cells. But let's first look at the numbers here. These numbers represent partial pressure of the two major gases. Partial pressure, by definition, is the amount of a certain gas in a mixture. It's given in millimeters mercury, which is a measure of pressure. You can think of this as just a simple amount, how much oxygen is in the atmosphere. Here we suggest there's 159 millimeters mercury of oxygen in the atmosphere. There's 0.3 millimeters mercury of carbon dioxide. So there's much more oxygen in the atmosphere than carbon dioxide. This is the air you breathe in. You inhale this atmospheric air, it enters the lungs. Now, when it gets to the lungs, it changes a bit because it mixes together with that residual volume that was left in the lungs. So really, your body is dealing with this air because it has mixed. It's a combination of atmospheric air and residual volume. So notice the oxygen levels are a little bit lower and the carbon dioxide levels are higher than in the atmosphere. The blood entering those pulmonary capillaries have a certain amount of those two gases. That's shown here. Deoxygenated blood that enters pulmonary capillaries has about 40 millimeters mercury of oxygen, 45 millimeters mercury of carbon dioxide. Notice the difference in the two gas concentrations. This tells you that oxygen is going to want to diffuse into the bloodstream because there's a concentration difference. So oxygen from the alveolar air, which is at 105 millimeters mercury, diffuses into the blood in the pulmonary capillaries because there's a lower amount of oxygen, high to low. Carbon dioxide diffuses the opposite direction. Because there's a larger amount of carbon dioxide in the deoxygenated blood than the alveolar air, carbon dioxide is going to diffuse out of the blood into the alveolar air. So we call that process of gas exchange external or pulmonary respiration. It is the gas exchange between alveoli and pulmonary capillaries. Internal respiration is gas exchange between systemic capillaries and tissue cells. So now we're looking at the amount of these gases in the oxygenated blood and compare the amount that's in tissue cells. Notice oxygen will now diffuse out of the blood into cells because there's a concentration difference. Oxygen in the bloodstream is at, oxygenated blood is at 100 millimeters mercury. Tissue cells is 40, so it's going to want to diffuse into those tissue cells. Carbon dioxide, since it's being generated by the tissue cells, there's going to be a larger amount of carbon dioxide in the cells compared to blood, and the carbon dioxide diffuses out of the cells into the blood. So we can keep this fairly simple as long as we understand that diffusion allows molecules to go from where there is a high amount of that gas to where there's a low amount of that gas. We just have specific names for these two types of diffusion: external respiration and internal respiration. The next video we're going to see a very similar drawing, but a different topic. We're going to be covering how these gases are transported within the bloodstream.